Hey, what's going on, you guys? This is Madam 81, and I'm coming back to you again. This story is from the Pittsburgh Gazette.com. You can definitely go check this out. The article is by Carolyn Y. Johnson of the Washington Post, and it says racist bias in a top health algorithm favors white patient over sicker blacks. A widely used algorithm that predicts which patients will benefit from extra medical care dramatically underestimates the health needs of the sickest black patients, amplifying long-standing racial disparities in medicine. Researchers have found. The problem was caught on in a algorithm sold by a leading healthcare services company called Optum to guide healthcare decision making for millions of people, but the same issue almost certainly exists in other tools used by other private companies, nonprofit health systems, and government agencies to manage health care of about 200 million people in the United States each year. The scientists reported in the journal Science. Correcting the bias would more than double the number of black patients flagged as risk of complicated medical needs within the health system. The researchers study, and they are already working with Optum to fix on a fix. Excuse me. Optum acknowledges that its software was the subject of the study in response responded Friday, calling the findings misleading because hospitals can and should supplement the company's cost algorithm with their own socioeconomic data. When the analysts on the national data set of 3.7 million patients, they found that black patients who were ranked by the algorithm as equally as in need of extra care as white patients were much sicker. They correctly suffered from 48,772 additional chronic diseases. It is truly inconceivable to me that anyone else's algorithm doesn't suffer from this, said Sanishi M., a professor of computation and behavioral science at the University of Chicago Booth School of Business, who oversaw the work. I'm hopeful that this causes the entire industry to say, "Oh my, we've got to fix this." The algorithm wasn't intentionally racist. In fact, the specifically included race instead to identify patients who would benefit from more medical support. The algorithm used a similarly race-blind measure how patients would cost the care system in the future. But cost isn't a race-neutral measure of healthcare need. Black patients incur about 1,800 less in medical costs per year than white patients with the same number of chronic conditions. Thus, the algorithm scored white patients as equally at risk of future health problems as black patients had been many more diseases. Machines increasingly make decisions to affect human life, and big organizations, particularly in healthcare, are trying to leverage massive data set to improve how they operate. They utilize data that may not appear to be racist or biased, but may have been heavily influenced by long-standing social, cultural, and instructional bias. Excuse me, institutional bias. such as healthcare costs. A computer system determined which job candidates should be interviewed, which should receive a loan, or how to triage sick people. The preliminary algorithm that powered them runs the risk of automatically racism or other human biases. In medicine, there is a long history of black patients facing barriers to accessing care and receiving less effective health care. Studies have found black patients are less likely to receive pain treatment, potential life saving lung cancer surgery, or cholesterol lowering drugs compared to white patients, such as disparities like have complicated roots, including explicit racism, access problem, lack of insurance, mistrust of the medical system, cultural misunderstanding, and unconscious bias the doctors may not even know they have. Mr. M, I'm not going to try to pronounce the name, my apologies, and his collaborators discovered that the algorithm they studied, which was designed to help health systems target patients who have the greatest future healthcare needs, was actually predicting how likely people were to use a lot of healthcare or rack up costs in the future. Since black patients generally use healthcare at lower rates, the algorithm was less likely to flag them as likely to use a lot of healthcare in the future. The algorithm then deepened that disparity by flagging healthier white patients as in need of more intensive management. Predictive algorithms that power those tools should be continuously reviewed and refined and supplemented by the information such as socioeconomic data to help clinicians make the best informed care decision for each patient. Optum spokesman Taylor Mason said, as we advise our customers, these tools should never be viewed as a substitute for a doctor's experts and knowledge of their patient's individual needs. Roha Benjamin, an associate professor of the African American Studies at Princeton University, drew a parallel to the way Hessiana Lax, a young African American mother with cervical cancer, was treated by the medical system. Miss Lax, Henrietta Lax. Side note: Henrietta Lax. She lived in Baltimore. She did have cervical cancer. Actually, a couple of my family members are directly linked to her as far as bloodline and things of that nature. They essentially took the cells from Henrietta Lacks. John Hopkins Hospital did that. Um, took her cells without permission, and they used that. And any person that has cancer, regardless if they're they like black people or don't like black people, they owe a thanks and appreciation in a moment to Henrietta Lacks, because her cells were the cells that sparked and created tests for diagnosis for different types of cancer, early detection, things of that nature. So shout out to Miss Henrietta Lacks. And then it goes on to say Miss Lacks is well known now because her cancer cells taken from without her consent are used throughout modern biomedical research. She was treated in the Negro wing of Johns Hopkins in the era when hospitals were segregated. Imagine if today, Miss Benjamin wrote in an accompanying article, Miss Lax were diligently triggered with an algorithm that didn't explicitly take into account her race but underestimated her sickness because it was using data that reflected historical biases to the project her future needs. Such racism, though not driven by hateful ideology, could have the same results as earlier segregation and substandard care. I am stuck by how many people still think that racism always has to be intentional and fueled by malice. They don't want to admit the racist effects of technology unless they can pinpoint the bigot boogeyman behind the screen. Miss Benjamin says the software used to predict patients needs more intensive medical support was an outgrown of the Affordable Care Act, which created financial incentives for health systems to keep people well instead of waiting to treat them when they got sick. Excuse me. The idea was that it would be possible to simultaneously contain costs and keep people healthier by identifying those patients at greater risk for becoming very sick and providing more resources to them. But because wealthy white people tend to utilize more healthcare, such as tools, also led healthcare systems to focus on them, missing an opportunity to help some of the sickest people. Christine V., Director of the Evaluation and Research at the Center of Population Health at the Partners Healthcare, a nonprofit health system in Massachusetts, said when her team first tested the algorithm, they mapped the highest scores in their patients population and found them, excuse me, I'm eating too, concentrated in some of the most influenced suburbs of Boston that led them to use the tool in limited ways, supplementing it with other information rather than using it off the shelf, which they should have done, which all healthcare systems should do. You're going to have to make sure people are savvy about it, or you're going to have an issue where you're only serving the richest and most wealthiest folks, Miss V said. Such bias may seem obvious in the hindsight, but algorithms are notoriously obscured because they are proprietary products that can cost hundreds of thousands of dollars. The researchers who conducted the new study had an unusual amount of access to the data that went into the algorithm and what it would predict. They also found a relatively straightforward way to fix the problem. Instead of just predicting which patients would incur the highest cost and use the most health care in the future, they tweaked the algorithm to make predictions about their future conditions. Suchi S., a machine learning and healthcare expert at Johns Hopkins University, said the study was fascinating because it showed how once a bias is detected, it can be corrected. Much of the scientific study of racial disparities in medicine provide evidence of inequality, but correcting those problems might requires sweeping social and cultural changes, as well as individual behavior changes by thousands of providers. In contrast, once a flawed algorithm is identified, the bias can be removed. The cool thing is that we easily measured the bias that had historically existed, switched out the algorithm, and corrected the bias, Ms. Sarita said. The trickier part may be developing an oversight mechanism that will detect the bias in the first place. Ms. Sarita said that one possibility is that the data experts could potentially test company algorithms for bias, the same way security firms test whether a company's cyber defenses are sufficient. Associated Press contributed to this article. Um, I chose to do this because it is very important to everyone, and I can't stress that enough. Everyone, that they know how the healthcare system is being run. Um, a lot of people have issues with insurance, regardless of the race. Um, and it just pointed out biases. And my whole thing about the whole situation is, um, it is 2019. It is 2019, and I still do not understand why this bias exists in healthcare. Um, that's just like big pharmaceutical companies. You know, they it was a story a couple of years ago about a young gentleman. He ran a pharmaceutical company, and he was charging for the specific drug. I think it was for cancer or something, real serious condition. He was charging about maybe 13 to 20% more, um, versus uh, drug manufacturers in Canada and Switzerland, other countries around the world. And it was an investigation into that, why he was. I'm not really sure what happened with that, or if the media just swept it underneath the rug. But pretty much after that, you didn't hear anything else. Healthcare costs. It's the actual drugs that's being developed and being made. A lot of people may not be aware of this, but a lot of the medicines that are made to help us for uh, races, medicines that work for our white counterparts or groups of people, does not necessarily work for people of African descent or black people, whichever you choose to identify yourself with, or other things. So you have to take that into account too. It's not just in cost and stuff like that too. It's actually in the drug making itself. Um, how many of our family members have had cancer, have had leukemia, have had Parkinson's disease, have had sickle cells, have had countless of other diseases that our white counterparts have, and the drugs work better for them than they do for um, actual people of color. I mean, this is not a racial fuel thing. This is basically, it is what it is. My aunt was a three-time cancer survivor, and they had her on all these drugs to the point to where, as though, she was about, almost 80, 77 or something like that. And she was like, I don't want to do this no more. I don't want to, like, it was so bad. I would assume that the pain was so bad for her. Like, she had an automatic morphine pump, with her at all times. And in her later years, she couldn't walk. She couldn't get out of bed. So, she just was like, you know what? I don't want to go through this no more. This is the last time. Let me just go. Let me go. and she was ready, and rightfully so. Shout out to Helen, um, the matriarch, one of the matriarchs of my family. So yeah, it's really crazy, but hopefully they will do something to address it. But more than likely, what they're going to do, they're going to make some changes. But is it really going to change? That's the question. I want to say thank you for sticking, through so long through this video. But I do think this is very important. Um, very, very important. Another side note for like as far as like John Hopkins, everybody knows. Well, everybody in Baltimore knows that John Hopkins is. It's a hospital on paper, but it's really a guinea pig farm. Like that's where you go. They want to test you. They want to. I mean, every hospital does that, but not so much more than John Hopkins. They are the one of the best hospitals in the world, known world over. Dr. Ben Carson, um, and countless other doctors and specialists have came from John Hopkins and work all over the world. But John Hopkins is a guinea pig. It's a guinea pig place. It's when you go and they'll find out what ails you, but they just might fuck around and kill you and take your cells and not get the okay from you or your family before they do it. That's just a basic knowledge. So again, thank you for sticking through with this video. Don't forget to like, subscribe, and share. Please, please, please drop down in the comments. Let me know what you think. Let me know how you feel about this. And until then, I will talk to you guys later.